Hello, and welcome to From the EBPL Archives, Encore presentations from the East Brunswick Public Library. I am your host, Melissa Hosick. This event was presented as part of our Just for the Health of It initiative. Just for the Health of It is a proprietary health literacy program developed by the East Brunswick Public Library to promote health literacy in Middlesex County. To learn more, visit justforthehealthofit.org. Now, enjoy the program.
Welcome and thank you for joining us this afternoon. My name is Kathy Chern and I am a consumer health librarian at East Brunswick Public Library. This Lunch and Learn presentation is sponsored by Regional Cancer Care Associates Central Jersey Division and the library's Just for the Health of It initiative to promote community health and wellness. Today's speakers are Dr. Craig Lampert, medical oncologist and hematologist, Regional Cancer Care Associates Central Jersey, and Dr. Philip Pancari, medical oncologist and hematologist, Regional Cancer Care Associates Central Jersey. Before I turn things over to today's speakers, I would like to ask you to please mute your microphone and turn off your video. If you have any questions, please type them into the chat box. Our presenters will answer questions at the end of the talk. Please note, the doctors presenting will not be able to offer personal medical advice to attendees during this program. Please be aware that this talk is being recorded and will be posted online at the library's YouTube page at ebpl.org/YouTube. And without further ado, I shall turn things over to the doctors.
Hi, I'm Dr. Craig Lampert. I'm a hematologist and medical oncologist at RCCA. Next slide. I'm going to be presenting along with my colleague, Dr. Philip Pancari, who likewise works with us at RCCA. Next slide. So I'm going to be talking a little bit about lymphomas, myelomas. Dr. Pancari will talk about myelodysplasia and leukemia. He will then follow with a little information about anemia. And then I will close off discussing how to stay safe and well during the COVID-19 pandemic. Next slide. So what is a lymphoma? A lymphoma essentially is a cancer of the immune system. The immune system basically protects us against, as you know, infections. And lymphoma involves a white cell that's involved in the immune system known as the lymphocyte. Now, if you look at a drop of blood, you'll see three kinds of cells. You'll see white cells, red cells, and platelets. White cells help us to fight infection, and there are different kinds of white cells. The lymphocyte is a type of white count and of white cell, and this is a cell that does become malignant in lymphoma. The immune system is basically a very large organ that involves the lymph nodes, the spleen, and the bone marrow. Next slide. Here you can see the immune system shown on a cartoon. The green roads essentially are the lymphatic vessels that attach to the lymph nodes, and the lymph system travels up and down between the lymph nodes. The spleen is the organ on the left, and that is a very important organ in the immune system. And then the bone marrow, which produces the blood, is also a pivotal part of the immune system. As you can see, the immune system essentially involves the whole body, and this becomes very important when we talk about staging and when we talk about spread of the disease. Next slide. So like any cell in the body, the cells of the immune system can become malignant. When this happens, we call it a lymphoma. Because the immune system is really one organ, the cancer can involve one lymph node, it can involve multiple lymph nodes, it can involve multiple lymph nodes and the spleen, and can also involve the bone marrow. Next slide. What we see over here is a lymph node that has been taken out of the shoulder, and the lymph node is a green bean-shaped structure. In reality, these are usually about the size of a peanut. And although you might not see it very well on the slide, the yellow dots represent lymphoma. Next slide. So lymphoma, there are many, many different kinds of lymphomas. A lot of people know about Hodgkin's disease. Hodgkin's disease is actually a somewhat rare lymphoma that occurs mainly in younger people, but certainly sometimes in older people. For the most part, it is largely curable, and patients do really well with Hodgkin's lymphoma. When looking at non-Hodgkin's lymphoma, as I said, there are many, many kinds, possibly upwards of 30 different kinds of non-Hodgkin's lymphomas. And they're broadly divided into three groups. The one is the high-grade lymphoma, which is somewhat rare, typically occurs in young males in Africa, but can be found worldwide, is curable, but does require pretty intensive therapy. Most of the lymphomas we're going to be dealing with fall somewhere between the intermediate grade lymphoma and the low grade lymphoma. Now, intermediate grade lymphomas tend to be more aggressive. They tend to grow a little quicker, but it's that feature of them growing quickly that also allows them to be largely curable. So most people with an intermediate grade lymphoma will be cured by their chemotherapy. By cured, we mean alive and free of disease ongoing. Low-grade lymphomas are kind of a good news, bad news scenario. On the one hand, they are very, very slow growing, tend to grow very slowly, take a while to be found, but it is also the low-grade component and slow growth component that also makes it very difficult or makes them essentially not curable, but controllable. So patients with low-grade lymphomas can live with their disease for many, many years, often for years before they're diagnosed. Once they're diagnosed, they often don't need treatment. And once they're treated, they usually have their disease go into essentially a kind of a remission, but then will relapse at some point, get retreated, and kind of have this up and down course. Next slide. So most of this we've discussed. We can go on to the next slide. This is a picture showing a gentleman's shoulder. Basically, what we can see is this big tennis ball shaped structure on his shoulder, and that is lymphoma. What that is basically a whole cluster of individual lymph nodes, and instead of them being all about the size of a peanut, they're probably around the size of a grape, and they're coming together as a cluster to form this, this structure. Next slide. Okay. People get very focused on stage, sometimes possibly more focused than they need to be in all diseases, but certainly lymphoma is a disease where stage is really not that important when it comes to how a patient will do and what kind of treatments they receive. We do have 4 stages, but again, as against other diseases, the staging is not that important. Stage 1 usually refers to one or a couple of lymph nodes in a very small area. Stage 2 is more than one area, but on the same side of the diaphragm being that muscle that separates the chest from the abdomen. Stage 3 is lymph nodes on both sides of the diaphragm, pretty much spread through most of the body. And then stage 4 is when other non-lymph node organs are involved, such as the bone marrow. Now, again, staging is really just a way for doctors to help define your extent of disease and what treatments are going to be used, but for the most part, don't necessarily impart a prognosis or a severity. Next slide. So this is a pathology slide, and what they've done is they've taken a lymph node and they've cut it open. And what we're seeing at the top is that pinkish area is the covering of the lymph node, and everything below that is the lymph node. And what you can see, certainly more towards the top of the picture, is this very dark purple area. That is basically a lymph node that is absolutely filled with lymphoma. Next slide. So symptoms of a lymphoma. Often lymphomas can be totally asymptomatic, especially the lower grade ones. They can sometimes grow for years, the low grade ones, without people really knowing about it. Many of the symptoms will depend on where the lymph node is. So potentially if it's in the chest and there's fairly bulky disease within the chest, it might give you a problem with breathing. If it's in the abdominal cavity, it could give you problems with abdominal discomfort or feeling full after just a small meal. There are what we call constitutional symptoms, which are symptoms that can happen usually with a higher grade lymphomas and also usually once you have a fair amount of disease. And there are three of those. There's fevers, there's night sweats, and weight loss. Again, fever isn't usually a mild fever. It's usually a pretty heavy fever that's recurrent, especially at night. The sweating is not just waking up and feeling a little bit of dampness behind your neck. It's usually significant sweats that are drenching, where you land up having to change your sheets and pajamas once or twice a night. And weight loss isn't a pound here or there, usually talking about 10-15% of body weight. As I say, this is usually the sign of a fairly advanced lymphoma. Advanced meaning that there's a fair amount of bulk within the body, not necessarily that it's more problematic, but just that it's causing more of an issue to the person's body. Next slide. Okay, so talking about high and intermediate grade lymphomas in general and also during COVID-19, because this is a curable disease, because it tends to grow pretty quickly, we generally do need to start treating relatively quickly. They are curable, and so we don't generally want to wait. The disease is straining the body's reserves, especially when we talk about things like fevers, night sweats, weight loss, and so we definitely do want to get treatment started. Treatment will decrease the immunity, but again, so does the disease, and so waiting on treatments because of COVID-19 does not necessarily make sense. Initially, we were very concerned about how patients with lymphoma were going to do during COVID. Some of the data coming out of China early on did suggest significant concerns for cancer patients in general and lymphoma patients specifically. But it does sound that some of the data was looking very much at much sicker patients that were already in the hospital, and that actually, as it turns out, that the data for patients on chemotherapy in general and also for patients with lymphoma is not as concerning as we initially thought. But definitely both the disease and the treatments will put you at higher risk, not for getting COVID, but for how you do with COVID. The treatments we're using are pretty standard, and we haven't found a necessity for intermediate and high-grade lymphomas to make any major changes. On recovery, the immunity will recover. The first 6 months are probably the most problematic, but thereafter the immunity does rapidly ramp up. Patients with higher grade lymphomas do tend to be a little younger and fitter, and so tend to have a little less risk. Telemed visits have allowed us to do frequent checks on our lymphoma patients without necessarily exposing them to office visits. And the treatments themselves are delivered every 3 weeks and last about 4.5 months. And none of that has changed during COVID. Next slide. So looking at low-grade lymphomas, as we discussed previously, the disease is typically very slow growing and you often don't need to rush into treatment. Many patients can go for years without treatment, even prior to COVID. The disease does interfere a little bit with immunity, and treatment does pose risks for COVID patients because they need to come in for office visits, and also some of the drugs can hamper the immune system. And so this is one of the reasons why we don't generally rush into treating these patients. But at the same time, if you are very symptomatic, we absolutely will go ahead and treat. That was what we did previously. That's what we do now, although we possibly during COVID would have a slightly higher threshold for treating than we did previously. As far as the drugs we use, specifically in this component of the disease, the low-grade lymphomas, fludarabine and bendamustine are two drugs that have been identified as significantly decreasing immunity. And for new patients, we are tending to shy away from these two medications. There were obviously bunches of patients that were already on therapy at the time, and we have not changed their therapies, especially if they were doing well and responding. But for new starts, we would probably avoid these two drugs. Rituxan, which is the mainstay of lymphoma treatment, and is used not only for treating, but also in low-grade lymphoma patients where we will sometimes give them a maintenance to keep the lymphoma away for longer. This does lower the immunity to a small degree. The other issue with low-grade lymphoma is that patients are generally a little older and have other comorbidities and therefore a little sicker, which makes it a little more concerning. Next slide. Okay, so some common questions related to lymphoma and COVID. Will my cancer spread during COVID? Well, if you're being treated, there's no reason why it should spread. In fact, it should be disappearing. But if you're not being treated, it will spread. Again, no quicker than previously. And the fact that the lymphoma is a disease that involves the whole body to start with, spread is not necessarily a dramatic concern or issue. Will I lose anything if there's a delay in treatment? Again, if it's a low-grade lymphoma, we're purposefully going to delay treatment. If it's a higher grade lymphoma, a small delay is probably not going to hurt, but we don't want that delay to be very long, more than just a couple of weeks or so, just because it is putting a stress on your body, and we don't necessarily want it to start causing problems with larger lymph nodes and more sites of disease. Will I be exposed to COVID during my treatments? Certainly speaking for RCCA, we were very, very proactive when coronavirus started, probably more so than any other practices in the area. We immediately started moving to telemedicine. We started our infusions earlier in the day and pushed them later in the night so we could spread patients out. We made sure that each patient was only having contact with one nurse, one provider, to limit the potential for exposure. But yes, versus sitting in your house alone, you are going to have more of a risk of exposure to COVID, but hopefully that's going to be limited. Will the cancer make me sicker if I get COVID? So if you have the cancer and or if you're on chemotherapy, you are going to have more of a challenge potentially with COVID. That does not mean that you're going to have a negative outcome. And many, many patients with cancer, with lymphoma, on chemotherapy, who have had COVID have made nice recoveries. So the answer is yes, your risk is a little higher, but you absolutely can recover. Do I need to get blood tests and scans? So as part of the workup and management of patients being treated, we do watch blood tests, we do watch scans. Not to say that we would ever get unnecessary scans, but we probably did get them a little more frequently than we're getting them now. We are pushing the scans out as much as possible to make sure that we're only getting scans that are absolutely necessary to make sure that patients are not getting any unnecessary exposure. If I'm not symptomatic from my low-grade lymphoma and it's not treated, am I safe? And the answer is absolutely. There is a mild decrease in immunity with a low-grade lymphoma, but if you're not symptomatic and you're not being treated, your risk is probably not that much higher. There are lots of people out there who probably have low-grade lymphoma who don't know it yet because it hasn't been diagnosed. And again, risk is not going to be dramatically higher. Next slide. Okay, so I just want to quickly move on to myeloma. Just a little bit of background. In our bone marrow, there are cells known as plasma cells, and these make antibodies. Antibodies are proteins that basically protect us against infections. Usually about 2 to 3% of the cells in the marrow, 3 to 4% are plasma cells. Like any other cell in the body, the plasma cell can become malignant. And when it does that, it's called myeloma. What happens in myeloma? Well, as with all cancers, the cell reproduces with no control. The marrow in this case gets filled with plasma cells. It displaces the normal marrow, and it produces very large amounts of those antibodies, the proteins that make it. Next slide. So here is a cartoon of this is actually a femur with the bone marrow in the middle. And at the top we have normal plasma cells, and each one producing normal amount of antibodies. Below we see myeloma cells. These are larger, they're ugly, they're not very uniform, and as you can see, they're producing a lot more of the antibody and protein than in the normal plasma cells. Next slide. So how does myeloma cause illness? Well, first of all, it displaces the normal marrow, so it makes it harder for your bone marrow to work. The antibodies, or those proteins, block the kidney, and that can cause kidney failure. It also breaks down the bones and causes fractures and high calcium. Because so much of the marrow has been taken over, the normal bone marrow is compromised, and therefore normal antibodies are decreased. So the abnormal ones are high, but the normal ones are decreased, and so the risk of infections is increased. Next slide. So this is a pathology slide of bone marrow. Bone marrow is kind of a little bit like a sponge, where the little individual air sacs is where the marrow lives and produces, and the walls making up the air sacs are bone. So what you can see here is that central stripe in the middle, the pink stripe, is bone, and then on either side are the marrow spaces. At the bottom, you see a normal marrow, which is showing cells being made at all stages of development, along with a normal amount of fatty tissue. But at the top, you can see a bone marrow that's been essentially totally replaced with plasma cells or myeloma cells. Next slide. This is a picture of somebody's forearm with myeloma. On the one end, you can see the fingers. On the other end is the elbow. The bone should be pretty much uniform, a uniform white, and what we're seeing are all these little punched out holes that is being caused by the myeloma. And if you can see a little closer to the wrist, you might even be able to see on the bottom bone, there's actually been a fracture through that bone because of the fact that the myeloma has so weakened the bone. Next slide. So myeloma treatment during COVID. Generally, we do need treatment relatively quickly. Again, a short wait is acceptable if kidney function and blood counts are normal. And when coronavirus first started, and we kind of thought this was just going to be a few weeks that we had to deal with it, there were some patients that were initially held off whose myeloma was not very aggressive. But once we realized this was going to be a longer term issue, we did not want to hold off any further and got, all patients were pretty much started immediately. Treatment will decrease immunity, but again, so does the disease. The antibodies that are needed are decreased in number, making you more risk for infection. Treatments have been pretty standard and no significant changes for COVID. Bone marrow transplantation is a very big component of treating myeloma, and for the most part has not been delayed. Now, there are some cancer centers where they are delaying or they were delaying transplants, but again, once the realization that COVID wasn't going away quickly and patients were at risk for relapse, my understanding is that most transplant centers are picking up with transplantation. There are no drugs in the treatment of myeloma that are specifically concerning as far as COVID. Yes, your risk for decreased immunity does exist with treatment, but again, so does the disease. So does the disease cause it. And as we get the myeloma under control, in general, your immunity is going to improve because you're at least losing the component of immune inhibition that was being caused by the myeloma. Maintenance therapy is a big part of myeloma treatment as well. And initially as well, that question was asked as to whether or not, patients should be on maintenance. Again, the risk for relapse if we stop maintenance is relatively high. And so we are continuing maintenance therapy. Next slide. And I will hand over to Dr. Pancari.
Hi, everyone. So I'm Dr. Philip Pancari. I work with Dr. Lampert here at RCCA. I'm going to start by talking a little bit about the myelodysplastic syndromes. This is often called MDS or myelodysplastic syndrome in the singular, but in truth, what it is a collection of different disorders with the same underlying pathology that together equal this sort of collection of conditions that fall under the larger category, myelodysplastic syndromes. So a little bit of a review. I know Dr. Lampert touched on this, but under normal conditions, the bone marrow is producing, really for our purposes, 3 types of cell that together make up the blood. The red cells are really for oxygenation. So the red cells, they pick up oxygen in the lungs and they transport it to wherever oxygen needs to go throughout the body. So they transport it to the heart and the kidney and the muscle, and essentially all throughout the body. The white cells, as Dr. Lampert touched on already, are there for immunity. So they fight infection. And actually, when you go to your doctor, you get often if you look at your labs, you may get a printout. The white cells have their own number, which may range, normally between about 3.5 and 11. In truth, there are several different types of white cell, and what we care about every bit as much as the actual amount of white cells is sort of what type of white cells do you have. Some of them are there to fight bacteria, some of them are there to fight viruses. Some of them are there to kind of look for early evidence of cancer, to try and fight that when it's still in the early stages. So white cells is a term that sort of encompasses many different types. And then the third component is your platelet count. The platelets are not actual cells. They're actually sort of small fragments of cells, almost like chips of cells that are responsible for clotting. So they intuitively, they stick together at a site where there's bleeding, and they form a clot. So we can move on to the next slide. So here's a quick depiction of the bone marrow. The bones are surrounded by this hard cortex, as we know, and then within it there's a spongier part, and it's within that spongier part that the bone marrow exists and where the blood is made. We're interested mainly in this red marrow, which is where what's called the myeloid lineage is produced. And as you can see here, they show the blood stem cell. The blood stem cell is able to produce all of this sort of more mature, differentiated types of blood. So from that blood stem cell come the red cells and the white cells and the platelets. So we can move to the next slide. So having reviewed the function of the bone marrow and the different types of cells that it makes, let's go back to the myelodysplastic syndromes. So what are they? It's essentially a failure of normal maturation. So as I discussed, there's the blood stem cell that should, give rise to healthy, normal, mature cells of different kinds. And what happens in this condition is that does not happen. So the name itself is actually a compound word, and it's actually descriptive all by itself. So myelo refers to what we call the myeloid lineage, and the myeloid lineage gives rise to most of the blood elements we're talking about. Not the lymphocytes, but it gives rise to the red cells and the type of white cell that fights bacteria. And dysplasia, the second part of the word myelodysplastic, means literally deformity. And the name comes from, if you look at a bone marrow under the microscope, if you look at a specimen from patients who have myelodysplasia under the microscope, you actually could see these cells, which instead of looking like healthy, developing, maturing cells, they look abnormal, they look a little bit deformed, and you can literally watch them having trouble developing into normal, healthy cells. Now, the myelodysplastic syndromes, it's actually a very wide scales, as it's sort of a wide variety of disease manifestations here. So you can have very indolent disease that doesn't behave very aggressively, and then you can have disease where the bone marrow is having very much a hard time making the blood instead of a little bit of a hard time. So I would say in early myelodysplasia, or we can call it MDS from this point forward. In early MDS, you might simply see that the cells are, patients are a little bit anemic because the bone marrow is not able to make quite as many red cells as it would like to make. In the later stages or in more severe disease, you can actually see it having a hard time making not only the red cells, but also the platelets and also the white cells. And occasionally what MDS has the ability to do, although this certainly doesn't happen with everybody, is the white cells that are having a difficult time maturing, they can evolve to the point where they can actually enter the blood in their immature form and become something called acute leukemia, which we'll talk about in a moment. Now, why does it happen? Patients come in, and I find one of the, I think realistically, understandably, one of the most common questions I get from people is, why did it happen? What makes the bone marrow, which had been healthy and doing a fine job for however many years, suddenly begin having a hard time making blood? And it's sort of, the short answer is it's sort of a cumulative damage and wearing out of the bone marrow is how I think of it. And what it is some damage to the DNA over time from exposures and from the need for the bone marrow, the cells in there, to constantly reproduce. Over time, errors are made in that process and they accumulate, mutations happen in the DNA. And as you can imagine, the older you are, the more time there has been for that to happen. So the more exposure to life the cells in the bone marrow have had, the more wear and tear, so to speak, and the more likely this condition is to develop. So next slide. Here's a chart of incidence of MDS diagnoses by age. And as you can see, it's remarkably rare in patients who are in their 30s or 40s. Once patients are in their 60s, you really embark upon kind of a steeper incline. And once patients get to their late 70s or 80s, it's much, much more common than in younger patients. And again, that's a reflection of this sort of wear and tear on the bone marrow, as I think of it, and mutations and DNA damage that happens over time simply from living, not necessarily from anything that a patient has done to make it happen. So we can move on to the next slide. Now, I think that this condition, it's very important to emphasize that one patient's MDS diagnosis it can be very different from another patient's MDS diagnosis. There are types of MDS that are very low risk, meaning that there's a little bit of an anemia, meaning the red cells aren't being made quite as efficiently as we would like. Otherwise, normal white count, normal platelet count, no leukemia cells, otherwise looking quite healthy. Patients may live with low risk disease for decades, maybe is basically shut down and is not making blood at all, or becoming an acute leukemia. So options for treatment are, they vary widely based upon where patients are on this spectrum. So if you're an MDS patient with low risk disease and you're only sort of mildly or moderately anemic, you may only need some what I call booster injections. Every week or two, you may need a dose of a blood hormone to get your bone marrow making blood a little bit more efficiently. For patients who have higher grade MDS, they may need actual infusions, not chemotherapy per se, but infusions to sort of train the bone marrow to try and function more normally. I'm talking about drugs called decitabine and azacitidine. Those are patients who have more serious disease. Occasionally we use pills to treat this disease, but that's a very limited subpopulation. And less commonly, stem cell transplantation. I'll note that this disease is not something that we cure unless we go in there and replace the entire bone marrow. And even then, not everybody is cured with that approach, although a pretty significant percentage of people are. A stem cell transplant is a risky endeavor on its own, especially because we're talking about a donor transplant, bone marrow from another patient to our patient. So we only do that if it's bad disease. If it's mild disease, only needing the occasional shot of Procrit or something, then in that case we would never consider a bone marrow transplant. So we can move on. So are MDS patients at a higher risk of COVID-19? The short answer is yes. As you can imagine, the bone marrow is not making the immune cells you would need to fight the COVID-19 as efficiently as we would like. Patients with MDS are often coming in to get labs or transfusions or injections, and they may, on account of that, be exposed, more likely to be exposed to people with the virus. And for patients who have MDS with significant anemia, they may be weakened by that anemia. So if they do catch the COVID-19, it may hit them harder if they're already anemic going into it. Better answer, however, is it's not everybody who has MDS that will necessarily be at a higher risk of COVID-19. As I mentioned, a lot of patients have mild disease that's barely affecting their white cells, which is what you need to fight infection. MDS, by its very nature, affects not the lymphocyte lineage that is responsible for fighting viruses specifically. So severe MDS, the whole bone marrow is sort of overtaken, but in a lot of cases of mild MDS, you could still fight viruses very well. So next slide. So sort of a spin-off of the MDS part, I mentioned that some patients can develop leukemia. So there are many reasons to develop leukemia. They're not all the type that's come from MDS, but here we have a picture of what happens in the blood. So let's say we take a drop of blood and we put it on a slide and we look at it under the microscope. Normal amounts of of white cells, as you can see on the left, those larger cells, those are normal white cells, and that's a normal amount of them. On the right, you can see mixed in with the red cells, you see a lot of white cells on the right, and those are many more than there should be there. So there should not be that many white cells circulating in the blood, and leukemia means that there are too many white cells in the blood. So we can move to the next slide. So there are two large categories of leukemia, and this actually is quite related to what Dr. Lampert was describing with lymphomas, aggressive versus non-aggressive lymphomas. Same idea is that the acute leukemias are aggressive, they divide more quickly, they make people sick quickly, they might be cured with aggressive chemotherapy because the more aggressive the cancer is, generally, the more likely it is to respond to chemotherapy, especially when it comes to blood cancers. The chronic leukemias are things you can live with for many years oftentimes. The white cells are not as immature. Actually, if you look at them under the microscope, they may resemble normal white cells. They don't even look abnormal much of the time. As I mentioned, patients may live with this for years. It may or may not even make them sick. They may or may not even have symptoms. One risk is that some of them can become acute leukemia if they're not treated and if they're allowed to progress without attention. But these can't be cured. So chronic leukemias cannot be cured because they don't respond as well to chemotherapy, but oftentimes we don't need to cure them because if they're not making somebody sick, we're not as worried about them. So next slide. So I wanted to put up a bit of a case report here. I have it because this condition, CLL or chronic lymphocytic leukemia, I think deserves a little bit of emphasis because of just how typical this situation is. And I see so many new patients who have had this exact thing happen to them. So I paint this picture of this 70-year-old man named John Smith who is otherwise healthy, has some normal medical conditions that many people have, like high blood pressure and cholesterol, sees his primary doctor every 6 months. and is sort of shocked one day at being told that his white cell count is suddenly higher than it should be. Initially, it's suspected to be from infection or inflammation or something reversible like that. So he may be given some antibiotics. He may have a culture done of his urine, but he doesn't feel like he has an infection, and there's no infection identified. About half a year later, he has his white cell count checked again, and it's higher still. So let's say normal is up to 11, and it was 13 the first time, and the second time, let's say it's 18 or 20. And his primary care doctor is concerned and says he may have leukemia and sends him to a hematologist. He still feels fine. So next slide. So here's what the hematologist finds under the microscope, which what we see are lymphocytes in this condition, chronic lymphocytic leukemia. And as I mentioned with chronic leukemias, if you compare one of those cells to what a normal non-leukemic lymphocyte should look like, they don't look any different. This actually looks very much like a normal lymphocyte, and that's because this is a chronic leukemia. The only difference, the only difference in what you're seeing is that there are too many of them. There should probably be one of those cells on that slide, not as many as there are. So we can move forward. Next slide. So after a confirmatory blood test that I won't get into, Mr. Smith is diagnosed with CLL. He's understandably concerned. He's being told he has a leukemia, but the hematologist tells him he doesn't need treatment. And that's because, as I mentioned, oftentimes these chronic leukemias, especially CLL, can be observed without any treatment. Reasons to treat CLL are if you were to get sick from it, if you were to have night sweats, profound weight loss, meaning 10 or 15% of his weight over half a year, profound fatigue to the point where he can't get out of bed, very large lymph nodes affecting his organ function, or if he becomes anemic or his platelet count starts to drop. Occasionally, so the white cell count just being high is not a reason to treat this type of chronic leukemia unless it really is rocketing up very quickly, and then we would consider it. So next slide. So treatment, when we do need to treat chronic lymphocytic leukemia, as with other chronic leukemias, it's not usually with aggressive chemotherapy. It's usually with a targeted infusion of something called an antibody that is there. Basically, it's an immune therapy is how I would think of it. Sometimes it's treated with a pill. So these patients are not usually really immunosuppressed from chemotherapy itself, but they are immunosuppressed, they are compromised from the condition CLL itself. Now, this condition, chronic lymphocytic leukemia, actually does affect the cells you need to fight viruses. So I would consider this condition to probably put somebody at probably slightly higher risk of catching COVID-19 and fighting it off if a patient has a type of disease that doesn't need to be treated. If a patient has that rare type of disease, which is becoming a problem and is needing treatment, the risk would be a little bit higher. So again, main idea, on average, for most people with this condition who are being observed rather than treated, may increase your risk by a little bit, but I would say not dramatically. So we can move on. So the final thing I will talk about here is anemia, and I'll be brief with it. So sort of the opposite problem we were seeing with the leukemia, with anemia, you have too few red cells. So on the left, you can see a normal blood smear, which is how the blood appears under a drop of blood appears under the microscope. On the right, you can see that there aren't nearly as many red cells as there should be. So as a consequence of that, there's not as much ability to pick up oxygen from the lung and to deliver it where it needs to go in the body. So next slide. What causes anemia? It breaks down into one of two things. There are really only two things which can cause anemia. One of them is the failure to make those red cells, and the second one is that they're being made, but they're being lost or they're being destroyed. So why would a patient be unable to make them? One reason would be if there are insufficient materials. So if the patient doesn't have enough iron, enough B12, vitamin B12, or enough folic acid. If there's a problem with the bone marrow machinery, so if the bone marrow is sick from MDS or leukemia, actually if there are kidney problems because the kidney has to make a hormone that tells the bone marrow to make blood. We call it EPO for short. So if there are kidney problems, that hormone isn't being made, so the bone marrow isn't getting the signal to make blood. And finally, inflammation from autoimmunity, or if patients have severe inflammation in their body, the iron gets trapped inside cells in the body, so it's not available to be used to make the red cells. So patients become anemic from inflammation. The second thing is a little bit more obvious, loss of blood. So if patients are bleeding, or if the red cells are being destroyed by the patient's own immune system, if it becomes confused, which I won't get too much into, it's a complicated situation called hemolysis. So we can move forward to the next slide. Symptoms of anemia are tiredness, shortness of breath. It can raise your heart rate. In severe cases, it can give patients chest pain. And these are consequences of the heart and other organs not getting as much blood as they need to have. Next slide. How is anemia treated depends upon the reason for the anemia. So first and foremost, I would say far and away the most common reason to see a patient for anemia is if they're losing blood, if it's a woman losing blood during her menstrual periods, or if it's an older person losing blood from an ulcer in their stomach that's bleeding very gradually, or gastritis. You can actually lose a lot of blood over time without realizing it's being lost. So you don't necessarily have to visualize blood in the toilet. You may be losing it little by little, and it may be invisible by virtue of what a small amount you're losing at a time. But over time, it builds up and it can make you anemic. Part of that is because you're losing iron. So as you're bleeding little by little over time, that's draining the iron from your body more quickly than you're taking it back in. And then that gives rise to difficulty making blood, and it's sort of a vicious circle at that point. If patients are short of vitamin B12 or folate, we give them back the B12 or the folate. If they're short of iron, we give them back the iron. We can give a drug called Procrit or Aranesp if patients have the kidney injury causing the anemia. If there's inflammation, as I mentioned, some inflammatory conditions can cause anemia, then you simply treat that condition. So if the patient has lupus, you treat their lupus, and that should help. Again, there's the hemolysis thing. If the red cells are being destroyed by the immune system, you suppress the immune system in order to stop that. And finally, if it's from leukemia or MDS, you would treat the leukemia or the MDS to improve the anemia. So it's very much not a one-size-fits-all type of thing. We have to evaluate each person and determine why they're anemic and treat it based on that. So next slide. So does anemia increase your risk of COVID-19? The short answer is no. It's not. It doesn't increase your chances of catching the virus. And it probably won't affect your ability to recover from the virus unless you have significant moderate to severe anemia. If it's mild anemia, the type that comes from menstruating normally or having sort of mild chronic anemia, I expect those patients to do as well with COVID as any other patient. But patients who have severe anemia that's undiagnosed and untreated, those patients, or anemia from chemotherapy or something like that, those patients are much more likely to get sick from COVID because they're already weakened and fatigued and maybe short of breath from the anemia. So if you put the COVID-19 on top of it, they may have a harder time getting over the virus. And I just want to mention my last point is we found that COVID-19 actually makes patients anemic. Kind of looking back to this comment I made about inflammation causing anemia, well, COVID-19 appears to be a very inflammatory type condition. So we find that patients we're seeing with COVID-19, they're becoming anemic from the actual virus itself. And I think I'm turning back over to Dr. Lampert.
Thanks, Phil. So I just wanted to talk a little bit about staying safe during coronavirus, during COVID-19. More specifically for lymphoma patients and cancer patients in general, but also really just for anybody. First and foremost, is social distancing. I think we all did this really, really well, but I think that now that things are starting to open up, there's this perception that the problem is over. Unfortunately, I don't think the problem is over, and I don't think the problem is going to be over for a while. People talk about it being better during the summer, the heat destroying the virus. I don't know that we know that for sure, and I think that especially for lymphoma and cancer patients in general, but for everybody, I think it's really important to continue social distancing. Social distancing by relatives and friends is something that also needs to be taken into account. if you're social distancing and you're staying home and you haven't left your house for 3 months, but your 19-year-old kid is hitting the bars and when they open, and meeting their friends and then coming home to you, the reality is you're not social distancing, because just like a chain is only as strong as its weakest link, you're only social distancing to the point where the people that you interact with are social distancing as well. Masks have gone through a lot of controversial turns over the last few months. We still don't know exactly the full benefit of masks, but it does seem clear that masks, for the most part, are not necessarily going to stop you from inhaling the virus. Unless you have a K95 or N95 that has an absolutely perfect fit, masks are probably not that beneficial. They probably help somewhat. But the bigger thing that masks absolutely do is that they stop you from giving the virus to somebody that you're close to. So again, if relatives are visiting, it is essential that you wear a mask, but it is probably even more essential that they wear a mask so that they will not be able to give it to you if they do have it. Roll of gloves. That's very interesting. I actually saw an interesting cartoon of a gentleman swimming in the ocean with gloves on. I will tell you that I have not worn gloves once. The only time I wear gloves is when I'm helping my wife skin the chicken, because I just don't like touching raw chicken. Gloves give you a really false sense of security. Essentially, if you have gloves on and you think that you're protected and you touch something and then bring that to your mouth or to your face, you're going to get coronavirus, you're going to get COVID-19, and there's no glove that's going to protect you from that. And if anything, gloves probably put you at risk by giving you that false sense of security. When I'm dealing with something that potentially could be exposed to COVID-19, I essentially see my hands as off limits. So I will deal with whatever it is that I'm dealing with, and then after that, I will go and wash them for 20, 30 seconds with soap, and at that point, my hands are now safe. Having gloves on is not going to help me, and as I say, if anything, it could make things worse. Rest, exercise, and nutrition, always very important, but especially important during coronavirus. You want to make sure that you're getting the rest you need, that even if you are stuck at home, that you're getting exercise, that you are eating properly as far as both nutritional and also amounts. If you do land up getting coronavirus and your body was well rested, well nourished previous to that, you're probably going to have an easier time getting through it than if you don't. Keeping social contact, likewise, very important, and that is not the opposite of social distancing. I think especially for children that have parents with a lymphoma or with a malignancy, making sure that you're in contact with them either by phone. iPads with FaceTime is absolutely wonderful. And I have to say, I'm absolutely amazed. I have 35 and 40-year-old patients that should be tech savvy coming on to Zoom and Doximity to do telemedicine consults with me that just cannot get their systems up and running. And then I have some 90-year-old lady who pops onto Zoom as if there was absolutely no problem. So I think that things like iPads, cell phones, smartphones are definitely great for helping social contact. Bringing children around, possibly outside, so that they can interact with their grandparents through the window, or possibly outside, but at a really, far distance, is definitely something that's going to be help people get through this. You also want to keep your other conditions under control. So if you have high blood pressure or diabetes, this is not the time to let your diabetes get out of control. This is not the time to run out of your blood pressure medicines. It is clear that people with other comorbidities, other medical problems, will definitely have a hard time if they get coronavirus. Flu vaccines and pneumonia vaccines. I don't know when we're going to be having a coronavirus or COVID-19 virus vaccine. I don't know if that's how effective they're going to be. But there is no question, if you can stop yourself from getting flu or pneumonia at the same time, or predating or after your COVID-19, again, you're going to be a whole lot healthier. So if you were someone that, stayed away from flu vaccines, it's probably time to start reevaluating that at this point. Next slide. Just a quick word about accessing medical care. When I look at, RCCA and what we did, we were very timely in moving over to telemedicine, in ensuring that we spaced out our chemotherapy patients starting at 7:30 a.m. and ending at 7 p.m. at night, so that there weren't too many people in the room, making sure that they were only exposed to the healthcare workers that were absolutely necessary. And moving forward, as doctors' offices open up, you're going to need to start evaluating how your doctors are doing things. You want to evaluate necessity of the appointment. Not specifically do you need to be there, but some of the appointments that you might have canceled before, it might be time to reevaluate whether you need to reestablish them, be that the dentist, be that the GYN, be that for mammograms. These are all things that need to kind of be picked up. Timely care is important, and you do not want to let things linger, because especially if coronavirus, if COVID-19 does continue for longer than we thought, that could be an issue. You want to assess your healthcare provider's office. There's nothing wrong with calling up your healthcare provider and asking them what they're doing to keep you safe. And if they kind of say to you, what is COVID-19? Maybe it's time to reassess that office. But if they tell you that they're, registering online, or they're going to let you sit in the car until your appointment, or they're only allowing 3 or 4 people in a waiting room, that's a little different to walking into a healthcare provider's office where there are 19 people, stuffed into a waiting room. I would like to believe that that is not going to happen in any office, but I think you want to make sure, and there's nothing wrong with asking and demanding of your healthcare provider to let them know what they're going to do to keep you safe. And then finally, taking responsibility for your health. That is always important. That is always should have been, without question. But I think that, here again, people have missed mammograms, people have missed GYN appointments. You need to make sure that you contact your providers to get these things up and running again. If you've had a blood test and you haven't heard from your provider, don't assume that everything is fine. A lot of the systems that we relied on in the past to prevent things from falling through the cracks have become a little more challenging now. And whilst we like to believe we're thinking about every contingency and evaluating every possible issue, it's not necessarily the case. And you do want to make sure that if you've had an X-ray, that you do hear from your provider that the X-ray is fine. And if you haven't, reach out to them and make sure that they give you the answers you need. I think Dr. Pancari and I are available now for questions.
So if anyone has any questions, please type them into the chat box, and please note that the doctors presenting will not be able to offer personal medical advice. Okay, so there was a question that was submitted. How often do you need a PET scan after you are cleared of non-Hodgkin's lymphoma?
So a lot of it depends on what kind of a lymphoma it was. If it was a higher grade lymphoma, if it was a lower grade lymphoma. If it was a higher grade lymphoma, we're probably doing them a little more commonly, somewhere between every 3 and 6 months afterwards. If it was a low grade lymphoma, you might not necessarily need one, especially now during COVID, because a lot of the time it's based on blood results, it's based on what you can feel, it's based on symptoms that you're having, and that can often be followed. So certainly with the higher grade lymphomas, we do want to make sure that if it were to be one of those less common situations where a patient did relapse, that we pick it up sooner. At the same time, we want to counterbalance that with, again, limiting exposure, of our patients to unnecessary healthcare.
Okay, then there's Another question, are there any food, supplements, or exercise/habit that you recommend to keep blood healthy?
So I think basically a normal balanced diet, if you eat just the standard recommended balanced diet, you know, if every category of food is well represented, you should be okay. Once in a while, a patient has very severe dietary restrictions that mean they're not getting enough iron or enough B12, and occasionally patients will have a absorption problem, either because of surgery they've had on their stomach or their bowel, or because of a condition, you know, within their gut that affects the absorption. But barring anything like that, typically if the patient has a normal diet, that's all I recommend. I think a daily multivitamin is a good idea, especially one containing B vitamins. And you know, it's a type of thing that following with even your primary care doctor will be able to pick up on, you know, by routine blood work, it will become obvious if you're becoming anemic, and the nature of the anemia will help us figure out, you know, are you missing something in your diet?
Okay, so I don't see any more questions coming in through the chat box. So I want to say thank you, Dr. Lampert and Dr. Pancari, for taking the time to talk to us. And as I mentioned at the beginning of this program, the talk is being recorded, and the link to the recording will be emailed to the registrants. It will be uploaded to the library's YouTube channel at ebpl.org/YouTube. And the next topic in this Lunch and Learn series will be skin cancer on June 12th. The presenters will be Dr. John Bauman, Dr. Darshan Vaidya, and Dr. Samir Desai. So thank you all for joining us today, and have a great day and stay safe.
Thank you.
Thank you for joining us for this week's Encore presentation. To join us for live programs or to learn more about the East Brunswick Public Library, visit our website at ebpl.org.